All right, welcome everyone to speak. Thank you for being here. Just a friendly reminder, if you'll go ahead and mute yourself for the presentation. We're super excited to welcome Melissa Peterson. She is going to be presenting about aging adults with Down syndrome and the risk for Alzheimer's disease. So I'm going to stop sharing my screen and make Melissa the host.
Perfect. Well, good afternoon, everyone. I think I'm still waiting on host status, and I will get that presentation shared. I wanted to check to see we're also able to offer this presentation as both an English and Spanish version. I don't know if there's anyone in the audience who would also like to have a Spanish version. I'm seeing anybody saying yes. Okay, so we will proceed then in English. Go ahead and get my slide shared. So first off, I want to thank the Down Syndrome Partnership of North Texas for the opportunity to present today. This presentation is brought by myself, Melissa Peterson, as well as a colleague, Raul Ventimiglia. We're both assistant professors here at the University of North Texas Health Sciences Center. And I'm going to be talking today on aging adults with Down syndrome and really cover the risk for Alzheimer's disease and how you can become involved in local research that we have. There's a couple of different objectives for this presentation. One is I'd like to help those attending really understand the features of Down syndrome across the lifespan, and that includes the age-related risk for things like Alzheimer's disease. I'm going to talk through also the pathophysiology and why individuals with Down syndrome have increased risk for things like Alzheimer's disease. What's the link? What do we understand there? I also want to talk about some of the limitations that we have to diagnosing cognitive changes, particularly in adults with Down syndrome, ways of identifying some of those early signs of cognitive change, and then also finally kind of touch on, what do we have going on here locally, particularly focused for adults with Down syndrome. So to start, many of you may know Down syndrome is really the most common genetic condition. It's also one of the most common causes of intellectual disability, and it occurs between 1 in 700 births in the US. It was initially described in 1866 by J. Langdon Down, but it really wasn't identified from a genetic stance until 1959, when they identified that it had to do with chromosome 21 and the fact that most people have 2 chromosomes. Individuals with Downs actually had a 3rd chromosome, and that was on that chromosome 21. The things that we're learning over time is that individuals with Down syndrome are really having increased lifespan. They're living longer. Various aspects of medical care, advocacy, health policy have all contributed to why these life expectancies have really doubled over the past 30 years. When we look at sort of what our estimates are, it's thought to be about 75% of adults with Down syndrome are actually expected to survive to the age of 50, with 25% of those expected to reach even 60 years of age. So folks are living longer, which is great. But that also means that there's a lot more medical comorbidities that come up. Some of those include hypothyroidism, vision loss, hearing impairment, obstructive sleep apnea, osteoarthritis. Several of these in and of themselves can also present and really simulate learning and memory difficulties. Hypothyroidism, vision loss, and hearing impairment being one of those factors. And you can think about it, if you're not seeing or you're not hearing information very well, it's really hard to learn, let alone recall information or complete tasks as you once did. Another big medical comorbidity that occurs is dementia. And that's to be expected. So now that folks are living longer, they're expected to have now increased lists for what we consider to be age-related conditions. So conditions that happen more often with age. Alzheimer's disease is one of those. And there's a really high prevalence rate among adults with Down syndrome for dementia, particularly Alzheimer's disease. The estimates have about 30% of those who are around age 50 have Alzheimer's disease versus reaching 50% for those who live up to 60. And the risk for Alzheimer's disease is really tied to that triplication of chromosome 21. So chromosome 21 actually encodes for the amyloid precursor protein. So this is the protein that produces amyloid. So it is really not a question of if they develop Alzheimer's disease, it's really a question of when. So they start really developing the Alzheimer's disease pathology. So from a biological stance, very early on, due to having trisomy 21. And there's been a lot of work looking at the pathophysiology of Alzheimer's disease in adults with Down syndrome. And the question being, how early is this protein occurring? So to give some perspective, so the A beta protein can build up over time. It happens in those with Down syndrome. It happens in the neurotypical population, but it occurs so much earlier among those with Down syndrome. So there's really this nice figure that Liz Head and colleagues developed to kind of show, how early. And their estimates really place it around starting at age 13. Folks start really developing amyloid in the brain, but it doesn't reach a point of being really pathologically critical until about age 40. And to kind of give some perspective on this, what they're experiencing at age 40 is what others in the neurotypical space are really experiencing over here at age 60. So their sort of trajectory and the development of this disease occurs really decades prior to others. And so this risk for Alzheimer's disease is very, very high for adults with Down syndrome, particularly as they continue to age. We've looked at over time kind of these trajectories of what do changes in the brain, changes in the structure of the brain, changes in memory and thinking look like. And the top figure there on the left shows the trajectory for adults without Down syndrome. And you can see it's much more spread out. It occurs really over a course of many, many years until they reach really about this time point, age 60. But if we're looking at kind of the same point of time for those without Down syndrome versus those with Down syndrome, you can see the arrows in red pointing to about the same point. This is around the, you can see the fact that those adults with Down syndrome have this tighter curve. Things change and happen faster and more congruent with each other, but they're also shifted. So the adults without Down syndrome start to present with some of these changes, but it takes a long time to sort of progress to dementia, whereas adults with Down syndrome present earlier, have more accumulation, more changes, and so the same time and trajectory look very different between the groups. And when we talk about Alzheimer's disease, I really want to put this in the context of it's really under this umbrella of dementia. And so this is a figure provided by the Alzheimer's Association that really shows that dementia is this very broad term. It captures a variety of conditions, Alzheimer's being really the most prevalent. But there are other types of dementia, Lewy body dementia, vascular dementia, frontal temporal, even a Parkinson's or Huntington's. When we really think about dementia, it's really captured in changes in memory and thinking. And then the crux of it is really daily functioning. So there's so much change in your memory and thinking that now it's impacting how you function on a day-to-day basis. This can look like your ability to manage medications, your ability to drive, your ability to navigate, manage your finances, be able to plan. So the memory piece is impacting so much so that now there's a functional piece to it. There are earlier stages, things like mild cognitive impairment, where you might have changes in your cognitive abilities, your memory, your thinking, but it doesn't have that daily functioning, that functional piece to it, that really make it classified as a dementia. And as I mentioned, Alzheimer's disease is really the most common type of dementia. It is often misdiagnosed. So there's other dementias that may be sort of the driving etiology. Alzheimer's is the most common, so it tends to be diagnosed more frequently as well. It's considered to be a progressive brain disorder and really taking anywhere from 10 to 20 years with regards to the progression, and that's for the neurotypical population. There's a variety of Alzheimer's disease symptoms that we think about. There's some big buckets, things like memory and learning, executive functioning, language, orientation, as well as mood. All of these are generally impacted areas by Alzheimer's disease. When I talk about learning and memory, what does that look like? Well, that looks like now difficulty learning new information, difficulty recalling dates, events that have happened. You may be repeating questions or misplacing personal items. And you may also need more what we call compensatory strategies. So that may be use of notes, reminders on your phone, alarms, different things that help you remember and kind of increase your ability to recall. Executive functioning is a really interesting area. It's a very complex frontal lobe activity. We think of it as your ability to plan or organize, your ability to problem solve or have good judgment. Things like, am I wearing the right appropriate clothes for the weather today? Your ability to manage things like medications, financial, how do you pay bills? How do you write a check? How do you manage, I need to take these pills in the morning and these pills in the evening. I can only take these every other day. It's your ability to really kind of have that higher order thinking and processing. Language is another big area where we'll have symptoms for those who have Alzheimer's disease. And that may be things like word finding difficulty, difficulty with name retrieval. It may even be things as simple as difficulty keeping up with conversations. You'll find folks who start to develop Alzheimer's disease become more and more reserved. They're less socially engaged because being social, having conversations is actually very cognitively tasking for an individual. You have to keep up with what you're saying, what they're saying, names, dates, people, where you're going with the conversation. And so there's a lot of different pieces that are required to be social and have that communication with others. Language or orientation is another area that's impacted by Alzheimer's disease, and that may be difficulty orienting to the date, the day of the week, the season. It may also present as difficulty with navigating, knowing where they're going, knowing how to get from place to place, and that can even be in familiar locations. Mood is another one. So folks with Alzheimer's disease tend to present with depression or increased anxiety. You'll also have paranoia, a lot of concern. They know they left something somewhere and now it's not there. Or they don't know where something was left, so they think somebody stole it or somebody moved it. So that can be also a big overlapping piece that's not as frequently talked about, but really should be. And there's really this continuum when we think about Alzheimer's disease. There's the preclinical AD stage, and that's really where you're not really presenting with any cognitive difficulties, you're not presenting with any functional difficulties. So things are going pretty well, but you may have some of that development of the pathology in your brain. So the disease might be progressing, but you're not really showing any indication of it. The mild cognitive impairment group is the group where you start to have changes. Maybe you start to have some difficulty learning, recalling information, but you can use strategies. You can use your phone, you can do notes, and you're able to really function day to day as you have before. It's not really impactful on your day-to-day functioning. When you move and transition into this purple, into this dementia due to AD stage, that's where you do have cognitive impairment, and it's to such a degree that it does now, as I mentioned before, impact that day-to-day functioning. So now you're having those problems managing your medications, managing finances. Maybe you're forgetting, did I pay that bill? No, I think I paid. So now you're overpaying or you're not paying at all. You might have poor judgment, not wearing the right clothes for the season that's out, forgetting appointments, forgetting to call folks maybe on their birthday. Different things are happening and it's impacting more and more of your day-to-day functioning. Maybe you're not wanting to go out to social events, not wanting to engage in different activities because you're now having word finding problems or trouble remembering information. And so now you have this more impactful day-to-day event. And that's where really you get to sort of that dementia due to AD. And then there's kind of a mild range, a moderate, and more severe range. There's a little bit of a difference though when we think of the early signs of Alzheimer's disease in those with Down syndrome. It doesn't look exactly the same as in our neurotypical population, although there can be a lot of overlap. Some things that may be kind of early indicators of the Alzheimer's disease might be memory loss that impacts daily life. So they may, let's say, example, have confusion or forgetfulness and something that was pretty typical for them. They always did the same set of events. So when they were leaving the house, they always did the same sequence of things. They always locked the door before they got in the car. And now they don't remember to lock the door, right? So we're starting to have these changes in something that's a very learned repetitive behavior. They might also have difficulty recalling even very well learned information. Things like their address, they might become forgetful of. They may have difficulty in planning or problem solving. And this can be particularly the case when you have multi-step activities or those that require sort of a sequence of events. So examples might be that they're not bringing a towel with them when they go to shower, even though they know that, this is a needing piece. Maybe they're not wearing the right clothes when they go outside. They're wanting to wear shorts and it's snowing. Or maybe they're not packing a sandwich in their lunch. So they're not remembering these multiple pieces. So they know, I take a lunch with me and they grab their lunch pack, but they don't put anything in it. They may have difficulty completing familiar tasks. There may be a decrease in their productivity or confusion in how to complete this task. So maybe how to make their lunch even though they've made the same lunch for a number of years. You might have confusion or disorientation, particularly to where they are, the place. So that maybe that they're calling loved ones to ask questions of, how do I get to this place when it was a place maybe they've continuously gone to for years or know quite well. They also might have some trouble understanding visual images or spatial relationships, and that might be navigating both outside of the home as well as within the home, including familiar locations, and maybe having difficulty now understanding signs and pictures and being able to kind of interpret, oh, that's what this sign means. Okay, this is how I need to behave. This is what I need to do. They might also have problems with language, and that can be speaking or writing. If they're able to also do that. It may be a lot of times a decrease in their expressive language. They might not be talking as much. They might be more reserved. Again, that social engagement is just very, very taxing for an individual and gets more so as the disease progresses. So that's one of the big things that you tend to see early on is that change in language. They might also have changes in their judgment. So, like I said, not locking the door when they leave, just leaving the house. Maybe they're throwing away items of value. Maybe they're very impulsive, or not really have a good safety awareness. So they just get on a bus without, telling somebody or communicating it, or even checking, like, is this the right bus that I need to be on? They're also going to have more withdrawal from social activities, be more reserved, and then they may also have some mood and personality changes, and that might be confusion, suspicion, paranoia, even depression and anxiety. There are neurocognitive changes that can occur across the lifespan for adults with Down syndrome. The pattern and sequence of cognitive changes for adults with Down syndrome is often pretty similar to the general population for those with Alzheimer's disease. There does tend to be a pretty significant deterioration in cognitive abilities in about a 28% of individuals around the age of 30. And those individuals tend to go on to have even higher cognitive impairment later on. So there's a group that's, we almost consider them sort of fast progressors. So they tend to see the biggest change early on, and then they have a bigger change as they progress versus others who experience a more moderate level of changes where, yes, they're experiencing some changes, but it's not grossly significant at a very, very young age. It tends to be more of kind of that slow progression that we would see with the neurotypical population. One of the big things that we see though, is that big percentage decline in their verbal ability. So that tends to be one of the very early, bigger indications of changes. And this is compared to even others who have Alzheimer's disease, or individuals, even with varying levels of intellectual functioning, those with Down syndrome seem to present with kind of that higher percentage of specifically a decline in that area. So verbal ability tends to be one of the earlier, bigger indicators of changes. Now, there are some problems with regards to diagnosing dementia in adults with Down syndrome. Dementia, as I mentioned, is a very broad category, and different groups have developed different sort of indicators for how do we determine and classify a dementia in one group. There have been several works that look specifically among those with intellectual disability to try to kind of propose, what might be indications of a dementia. And a lot of those have really been based on not necessarily cognitive performance, but kind of non-cognitive indicators. So it may be emotion, it may be functionality. A lot of it, though, does require notification of a change in their status. So it's really this ability to say they could do this previously and now they don't, or it's harder for them to do it, or there's a change in their level of being able to do this task. Longitudinal assessments are really good because it allows us to really have that baseline indication to say, okay, here's how they were. And now doing really a U to U comparison, how do they change over time? There has been sort of a big push in the field to really look at, can we use blood? Can we use imaging to help diagnose Alzheimer's disease, particularly in adults with Down syndrome, because it is very challenging to diagnose them with dementia. There has been a lot of work that's very positively looked at these different utilities, but there are still some limitations with cost, with level of invasiveness. Neuropsych assessment is usually one of the best things that we can do, just because it gives us a nice sense of sort of where an individual is at, and that is incredibly helpful with trying to diagnose dementia in those with Down syndrome. But there's some nuances to this. There's a lot of variability in even baseline cognitive abilities. Everybody presents a little bit differently, so it's not the same course or the same sequence or the same presentation. So one adult may present with some language changes, where another one may present with more problem-solving changes. There's not really robust set of diagnostic tools or tests, although we are getting more and more as we go with regards to ones that are designed specifically for adults with Down syndrome. There's also a concern with some of the assessment with regards to what we call floor effects. And what that is when we give cognitive testing, we really want to look across the span. So we really want to be able to know, how do you perform relative to others of your same age and education, but we really need to have this understanding of range. And if there's a lot of people performing at sort of the floor level, at the base level, indicating differences is really hard because it almost kind of caps you at a certain level. Most tests are designed to really capture that range. So you have some people in the normal area, some people maybe high average, some people low average. But when you have folks that are very low in functioning and low in abilities, it can be hard to then kind of capture some of that range when they're really more at the floor level of that. So there's some nuances in being able to use and select good measures to be able to help sort of detect that varying ranges we need. And that's particularly for sort of that range of intellectual functioning. There's also a really big importance on family and caregiver reports. And so we know um, when you're going through, the healthcare system and in meeting with providers, there's really a limited amount of time that you get to spend with any type of provider. I think the average at one point for a primary care provider was an 18-minute encounter. And if you think about how much you go over in a medical visit, you talk about your medications, recurring problems, that really eats up a lot of your time. So there's not a ton of time to really get perspectives from the patient, from the family. And so these cognitive evaluations and neuropsych tests really provide a deeper opportunity for family, for caregivers to really weigh in on how they feel their family member is doing and to provide really rich information on, are there changes and what are they noticing? I want to put a plug that we do have here at the Health Sciences Center, a center for older adults, and they are able to do these different type of evaluation and assessments. It is not common that we see adults with Down syndrome, but they have been evaluated in our clinics before. So if you do have concerns for yourself or others that you're experiencing some kind of change in memory or thinking, you want to get that evaluation, I've included their name and information there as just a point of reference for you guys. I also want to touch on, there's a lot of caregivers out there, particularly for adults with Down syndrome who also are experiencing Alzheimer's disease. So I want to kind of touch on, what can you do as caregivers? So we talked on, what were some of the early signs? What does Alzheimer's disease symptoms look like? And now it's kind of the other side of it. Okay, maybe you have a family member, you're caring for someone, or somebody with Alzheimer's disease. What do you need to do or adjust as a caregiver to make this path, this course a little bit more manageable? And one thing maybe that you can consider adjusting sort of your traditional methods or approaching in your responses, particularly for those who are experiencing this change in their learning and memory. Things like the use of incentives or rewards might actually become counterproductive versus being productive and helpful because it requires an individual to remember that incentive. Individuals who are having problems with learning and memory are likely going to forget, oh, I was eating all of my vegetables because we were going to go to the park later. They may forget sort of that incentive or reward for why they're doing a particular behavior. There may also be a change in their ability to learn and recall new rules. Or how they need to behave in certain situations. So the cueing reminder of that's not how we behave there may have some challenges because they may not recall, oh, this is how we need to behave in this setting. Things like attempting to negotiate, use logic, reason also becomes more difficult as folks age and the disease course progresses. They're not able to really think through or reason as well as they may have in prior. Communication is also really important. It's not just what you say, it's how you say it as well. So think of, when you're interacting with a young kid, they might not know all the words that you're saying, but they know your tone. They know how you're presenting, your facial expressions, your body language. They can pick up on those nonverbal cues, and it's almost as important for the communication as what you're saying in the verbal cues, is because individuals, as particularly as they progress with regards to the disease, they're going to pick up a lot more on those nonverbal cues. And that may be also particularly the case because they have that bigger change in their verbal abilities. And so now the nonverbal really becomes how they're interacting, how they're really engaging. So creating kind of that atmosphere, trying to create kind of a safe environment, especially if you're getting pushback. So using a lot of negative words, kind of harsh body tone language can be counterproductive and cause more defensiveness. So trying to use more positive, neutral language, redirect, can be helpful, particularly as the disease progresses. Some communication sort of tips are to use just short, simple words, simple sentences, one-step directions versus multi. Asking one question at a time. Sometimes it's hard if you're asking more than one for somebody to keep up and say, okay, I'm answering this, and now here's the next piece of the question. Some other suggestions might be providing choices or suggestions over open-ended questions. What do I mean by that? Rather than saying, what do you want for breakfast? Asking, would you like cereal or pancakes? Right? So I've given a choice. I've given some suggestions for them to answer. I've kept it short. I've kept, one question. So that provides them with the opportunity to really focus on what's being asked. It can also be helpful to repeat information or questions and then make a statement versus ask a question. So that may look like, do you want to go versus let's go. To make it more directive, this is what we're indicating, this is what we need to be doing. Different behavior tips that might be useful too is looking and being mindful of some behavioral triggers. So there may be frustration that comes with tasks that are really complex or there's multiple pieces to it. So they might be more agitated, more frustrated because of that. Environmental stressors. It's really loud. There's not very good lighting. It's really disruptive. People are making a lot of noise around them. So they're trying to complete something, but there's a lot going on around them. There may be some personal changes and changes to where they live, loved ones, caregivers, staff members who are helping to interact with them. So they're having on top of, some difficulty with memory and thinking. And they also might have communication problems, so misunderstanding what others are saying or what they're being asked to do. And those might trigger some concern. A lot of times, reassurance, having that neutral, positive communication can be really helpful. Redirection or distraction can also be helpful with kind of navigating some of these instances. Trying to be patient and calm and know that, your response and your nonverbal cues can also sort of escalate and impact the situation. So if you're able to stay calm, there's a better likelihood they're also able to remain as calm as can be expected in certain situations. So with all that being said, I'm going to end and then open it up for some questions. Talking about some of the research that we have ongoing, particularly as it relates to those in the local community and those with Down syndrome. So to start, there is a large ongoing local research effort to really study how people age. The study is called the Health and Aging Brain Study, Health Disparities. It is ongoing here at the University of North Texas Health Sciences Center. We have seen people for several years, so it's a 2-year follow-up period, and we have folks coming in for visit 3s, visit 4s, so it's a longitudinal study, trying to really understand how people change. We're focusing recruitment on really the US population. So our participants include those who are non-Hispanic white, those are who are Hispanic, and those who are non-Hispanic Black. The goal of the really study is to characterize and really capture and try to understand why some people go on to develop different diseases like Alzheimer's disease and others don't. What is the difference? What is your risk? Is it where you live? Is it different diseases that you may have developed? Or maybe it's the point in your life that you developed a certain disease. So maybe you developed diabetes in your 30s versus your 40s, and that's critical to know. Maybe you got treatment for it in your 30s and that was helpful and reduced your risk, and maybe versus somebody else who didn't start treatment until they were in their 40s. So all participants who are enrolled in this study undergo what we call a clinical interview, and that's really to understand your education, where you live, your occupation, we cover medication, we cover chronic stress, we cover social support. We cover, where you live, looking at your area. Do you have access to hospitals, urgent cares, to a doctor? Do you have a doctor yourself? Or, are you having to travel? Do you have really limited selection in grocery stores? Maybe you just have a convenience store near where you live, versus others who have Whole Foods and a Kroger and an HEB all within a 30-minute radius. So we try to really capture sort of this broad understanding of you. Then we also do a functional medical exam. So we do different walking measures because they've done some work showing that there are some gait changes that happen, and the understanding of can changes in our gait help us understand disease course progression. We also do a blood draw and storage of samples. So we look at the ability to, can we use your blood? Can we look at proteins in your blood to help us understand, your disease and what does the progression look like? We do testing of your memory and thinking. We also look, so that takes a picture of how is your brain working. We also take another picture of really how does your brain look? So we ask that folks engage in an MRI of the brain as well as PET scans, and that allows us to really look at the structure of how your brain looks. And then there's also clinical labs. So if you've ever been to a primary care provider and they've run your white blood cell, your glucose, those different measures, your cholesterol, we also run that as well. And there's a variety of these pieces that we provide back to the participants themselves. We provide back information on your memory testing, so how you did. We provide back that MRI of the brain. So what does the picture of your brain look like? We provide back that clinical lab. And all participants who undergo this study are paid for their time. We definitely want to compensate folks for providing everything they do for the study and for kind of driving this knowledge forward. And a lot of times folks engage in these studies really to help the future generations. Maybe they had a family member with Alzheimer's disease. Maybe it's a parent, maybe it's a sibling. And so they would like to kind of further help our understanding and help, their kids or their kids' kids, so the younger generation. Our age of enrollment now goes down to age 30. So we're looking at everybody from 30 and above to be able to look at these changes. So everything I covered there, so all of these in the little grouping here, would be completed every 2 years. And so it really gives that opportunity to say, how am I aging? What does this look like? What are changes? Yes, so somebody asked in the thread if thyroid symptoms can look like early memory problems. Yes. So hypothyroidism is often associated with cognitive slowing. So it can mimic that if treated. Oftentimes people see an improvement in their cognitive functioning abilities as well. So I jumped ahead of myself. So that was the Health and Aging Brain Study, Health Disparities. We are enrolling for that study, and a really exciting addition to HABS HD will be recruitment of adults with Down syndrome. So right now the enrollment is proposed to start in the spring of 2025. There's some space issues that have pushed us out. So it's looking like the spring, we'll be able to start enrollment specifically of this group of adults. The target population, again, is we want to stay representative of the US. So we're interested in folks who come who are non-Hispanic white, who are Hispanic, and those who are non-Hispanic and Black. And so we really want to get this picture of similar to what we're doing in HABS HD, but in those with Down syndrome is how do you age? The protocol will look a little bit different with this iteration. We're trying to really shorten how much time is spent in the study so we really can reduce down participant burden. It's pilot work, and so it's really that feasibility of do we feel like the Down syndrome community also feels this is useful? To also engage and get feedback of, do they feel like we're giving back useful information? Is this helpful? And so the proposed design is to ask a similar interview type structure with both the adult as well as with a caregiver or informant. There would also be a blood draw to look at blood. This would also be a part of those clinical labs so that we could.
Kayla, Alexa,
Oh, do we get a question? Sorry.
Question in the chat.
Okay. Memory and thinking testing, with the goal being of trying to help with some of that diagnostics. And so we'd be able to give you that information back with regards to, is there a change in memory and thinking? What do we think kind of the range is? Is it falling in that cognitively unimpaired grouping? Is it maybe in that mild cognitive impairment area? Or maybe have we moved into the dementia range? Again, and this is specific for those adults with Down syndrome. This can be incredibly useful because seeing providers specifically for that question is challenging. It's hard to be able to get the information as comprehensively as maybe we would like to be able to provide that indication to the participant, to that adult, as well as to their family and caregivers as well. So we would be able to give back a lot of information. The goal being that we would continue to build this program out. We would also be able to see folks over time. So again, we'd be able to provide that same you to you type of comparison and change. We had a question in the chat. I can pull that up. Yeah, so cataracts and hearing impairment are big things that can happen. Different medical comorbidities can also be really impactful. So they have high rates of obesity, diabetes, and all of those we've shown in some work can also impact memory and thinking abilities as well. So trying to manage those different medical conditions can impact kind of that cognitive ability and your ability to function on day to day. So those are some of the big ones. There is actually a really high percentage of hearing and visual impairment that happens with adults with Down syndrome, and that tends to be some of the early indicators, but folks don't necessarily know to report them. So a lot of times hearing impairments and visual impairments tend to go unnoticed for a period of time. So making sure that those are getting evaluated can be really helpful. Just and it happens in all areas. You know, you start to lose hearing, and it may be that you don't realize it, and so you just ask people, hey, can you repeat yourself, or can you say that again? But it's really a hearing impairment indicating, you know, if maybe that was treated, there could be some improvement. There was a question about, yes, the NTG EDS, yes, so we will be using that. So the cognitive battery for the Down syndrome cohort of HABS HD will be a little bit different from what we do in HABS HD, and will include specific measures, and a lot of these where you have that caregiver report piece to really help understand you know, what those changes are and what they look like. So there's actually more caregiver questionnaires with regards to the HABS HD Down syndrome cohort. I want to thank you all for being a part of this presentation today. I think I answered a couple of the questions in the chat, but if you have other ones, I am happy to answer those at this time. I also have on this slide deck some resources. Ooh, cursor. Things like Alzheimer's and Down syndrome, practical guidebook, aging and Down syndrome, Alzheimer's Association. All of these links are available with this slide deck. And I can pass that along to Whitney and the team. as I mentioned, and stop sharing, and I'm happy to address any questions you guys might have.
Will they put something out for signing up for the study next year for getting or recruiting people with Down syndrome?
Absolutely. So we will connect with organizations like the Down Syndrome Partnership of North Texas so that they can hopefully disperse some of that information to get you guys the contact information and how to get in touch with it. It'll also list the inclusion criteria of what we're looking for. So right now we have the age going down to 18. I'm hoping to keep it that way. It may shift a little bit. So we'll be able to kind of provide the fine nuances of the age, the inclusion, how to enroll, what's included in the study itself.
And I have one more question. So are you working with like Global Down Syndrome or any of those where you're cooperating with them for the research as well?
So we're also a collaborating site with the Alzheimer's Biomarker Consortium Down Syndrome, so ABCDS. It's one of the largest Down syndrome studies, and it's also global. So there are sites here in the US as well as over in England. They are one of the largest studies focused on aging in Down syndrome. So we are a collaborating site with them. We don't do the recruitment of adults, but we help them on the lab side. So we actually process all of their blood samples.
Thank you. They report at the National Down Syndrome Congress convention every year, and and that one does. But I just wanted to make sure that everybody was coordinating and not off in a silo. Thank you.
Absolutely. No, I love it. Thank you for bringing it up. Absolutely. And then the more people we can get involved, the more people we can bring together. And that's part of why HABS HD is really extending into Down syndrome, as there's such a huge need and there's a huge population, as you guys know, of adults with Down syndrome in our own local community. And we really don't have the clinic care to be able to help say, okay, they're experiencing cognitive changes, functional changes. What does that look like? What does that mean? How can you, as a family member, a caregiver, as that adult, what can you do about it? We don't have information really available for them as other communities have. We also don't have all the connections to kind of those cutting edge clinical trials or the research that's really out there that are recruiting and trying to really help move towards better diagnosis, towards better treatment for these adults with Down syndrome who are at this increased risk. We just, as a community, haven't really created the structure, the connections just yet as we need that, could really maximize our opportunities to really get folks, better care, better treatment, and hopefully better options moving forward. So that's really what we're trying to help do is sort of fill that gap and fill that need and connect with, the local organizations that we have here, the different centers, the different groups to really try to help maximize, what we can offer and what we can do to this community. So again, I appreciate all of you guys being a part of this today. Any question?
Thank you. Appreciate the update.
Thank you, guys.
Thank you, Melissa, so much. This was so informative, and we really appreciate you taking the time and presenting to us. This will also be recorded and uploaded on our YouTube site, and I'll send it out to all the participants. And so if you wanted to share it with other people that that would be interested, that would be great.
And I'm also happy to share my slide deck in case folks want to look at the resources or anything that we have there. So I'm happy to pass that along.
Perfect. Well, thank you so much. We really appreciate it, and we'll be in touch.
Sounds good. Thank you guys all for your time. Appreciate it.
Thank you.